So I want to just talk a little bit about what we've been doing. Over the last year, we've had over 500 outreach visits. We meaning you guys. You guys have done this. You guys are the boots on the ground. You need to know, and I think you do, you're saving lives out there with what we're doing here, and we're really, really proud that you're working with us on it. Over the last 2 years, we've had almost a 60%. Chief Allen calls it 59. I call it almost 60. I think it sounds a little bit better. Almost a 60% successful engagement rate. So 60% of the time we find people that are entering some type of a treatment program. So we're all obviously very proud of that as well. I think most of you know that we received a BJA grant to start hiring people and maybe as well as funding some of the recovery coaches. So that grant will be ready to start funding somewhere in January, Chief. Somewhere mid-January is the thought. They told us mid-December, so we're figuring a month for the feds to work through that, and we're thinking mid-January. So we've posted a couple of positions, a coordinator position and an operations position, and we've gotten over 70 applications for those two positions altogether. So there's a lot of interest out there, a lot of people that want to help and want to step up for those positions. We'll be doing phone interviews in the next week or so, and then we should have that filled by the first of the year. As I mentioned, the recovery coaches will be able to pay per diem for some recovery coaches to start working with us. The grant's just under $500,000, and we're hoping to continue down that path as well. We did have some recognition at the IACP, which is the International Association of Chiefs of Police. We got a Community Policing Award down there. We had quite a few of our members down there with us. Both Chief Olson and Lieutenant Linehan were with us. And that was a great effort. Chief Allen's going to talk a little bit later on about some of the other recognitions and where we're going with this. There were a lot of places where we've been presenting the program, and I don't want to get into what he's going to talk about, but he's going to talk about where we've been and what we've been doing with that, okay? We've gotten a lot of support from HIDTA, the High Intensity Drug Trafficking Area program. They've funded KRA, our partners, Pam and Kelly up front here. I mean, Pam and Sean. They've been funding that maintenance for us, and we're going to be presenting in January at that board to try to get another year of funding, and we're pretty confident we're going to get that. So with that, let's see. I'll bring Chief Allen up to tell you a little bit about today and the agenda, and he's going to introduce the guests.
And then Chief will interrupt me. Real quick, I just want to thank everyone. We want to get to our features here, so I'll be brief. Today we're going to do medically assisted treatment, opioid treatment programs through Dr. Kehoe and Dr. Wally, who I'll introduce in a second. But before I get to that, we just ran the numbers this year to date compared to last year. Fatals are down countywide 25%. Non-fatals are down 13%. Our at-risk individuals, and they're going to hit on, I don't want to steal the thunder from the data team because they're getting mad at me already, but I just want everyone to know you're doing this great work. Those at-risk are going through the roof this year to last year, and that's because of the work that you people are doing, not the work that we're doing up here. After that, we're going to have Pam Kelly and Sean Verano from Kelly Research Associates. They're going to go over they're actually rolling something, a new piece out that I won't introduce, so you guys can do that in the surprise. But we're real excited over the next year. We're going to have a new server, new system that they're going to show you, and then talk about some of the data stuff. We want to thank Vicki and Hannah, Vicki Butler and Hannah Carpenter, for all the yeoman's work that they're doing as PCO coordinators. Without them, this wouldn't happen. I know many of you hear from them day to day, so that now it's not emails from me or Chief Poteri, but they're doing great work out there. And then at the end of today, we do want to get your feedback. We did this last time. We did this here in February. We had some great feedback, ideas, suggestions that you as the team members on the ground want to do. So we're going to be looking for that as well. So with that, I'm going to introduce our two keynote speakers here, our guest speakers. We have Dr. Kehoe, Laura Kehoe, the Medical Director of Mass General Hospital's Substance Use Disorder Bridge Clinic, which is a component of MGH Substance Use Disorder Narrative. She's an Assistant Professor of Medicine at Harvard Medical, and she received her AB from Washington University in St. Louis, her MD from Tufts University, and an MPH from BU School of Public Health, which we have another BU school graduate here, Dr. Alexander Wally, an Associate Professor of Medicine at BU School of Medicine, the Director of the Boston Medical Center Addiction Medicine Fellowship Program. He is the Medical Director for the Massachusetts Department of Public Health's Opioid Overdose Prevention Pilot Program, provides primary care and office-based addiction treatment for patients with HIV at BMC, and then methadone maintenance treatment at healthcare resource centers. So with that, I'm going to turn it over to the two doctors. Thank you very much for coming out. We look forward to hearing from you.
Thank you. Thank you. Thank you so much. Before I start, I wanted to thank the chiefs and for everybody here. I've been practicing medicine for about 20 years, and for the majority of the time I've been treating patients with addiction, multiple addictions. And it was when I was able to actually figure out how to treat people that my life was impacted, because I could actually help people and felt really rewarded in the practice of medicine. And another really salient time in my career of taking care of patients was when I got to partner with first responders like those of you who are here, and treatment providers, as really a true public health, all hands on deck. And so I just want to thank you for partnering with us, because that's really making the difference in not only keeping people alive, but getting them into meaningful care. So today I'm going to talk about the treatment for opioid use disorder. And what we're going to start with is, hopefully you're going to leave with an understanding, many of you know this already, but to review, that this is a chronic relapsing illness, much like many other illnesses we treat in medicine, and to be able to describe effective treatment for opioid use disorder. And if we have time, review Mass General's response and how we have innovated and changed our approach. As many of you know, drug overdoses now have surged beyond many other public health crises that we've experienced in our country. Now it's the leading cause of death in adults under 50 or 50 and under. And when you think about that, these are people who are otherwise young and healthy. We've far surpassed car accidents, gun violence, and the peak of the AIDS crisis. And that's one that I think people really kind of respond to, that we've gone way beyond that. We're truly in a crisis, that we're really kind of, again, public health, all hands on deck. And when we look at kind of the whole spectrum of the overdose deaths, they're really described 3 waves of the crisis. The first one, as we know, with the vast overprescribing of pain meds in the 90s, we saw this initial rise when many of us were practicing before it was declared an opioid epidemic. We saw the epidemic evolving, and there was a rise in prescription opioid overdose deaths. And then as we actually started to address this with misuse deterrent medications, with really an expansive effort in educating doctors and other prescribers in pain management, we actually saw a dip in the prescription drug monitoring in the around 2012 in those opioid overdose from oral opioids. And what we found was, not for every death that was saved, there was actually a steep and scary incline, that orange line, and a rise in heroin overdose deaths. And what the message with that is although we've kind of decreased the prescribing, we still had this enormous pool of people with opioid use disorder in need of treatment. And so the natural history for people often with opioid use disorder is to escalate to a very scary and illicit form of cheaper, much more readily available drug, opioid, heroin. And then shortly thereafter, as we're seeing now, is this has really become a poisoning epidemic of fentanyl, which is an opioid that's significantly more potent than heroin, in this steep, straight, vertical incline, despite all of our efforts, where the overdose deaths are continuing. And Alex will talk about that. So this is really now a synthetic opioid overdose. I can't remember the last time I saw heroin and toxicology screens. And really, patients are also not knowing kind of what they're getting and the potency. We're assuming that everybody is pretty much getting fentanyl at this point, and that speaks to how we're keeping people safe. The other thing is, this is why we're all here. We often say 10% of people receive treatment. Another more impactful way to think about it is 90% of people with this treatable illness are not receiving evidence-based care. And really what this gets to is what we have. We don't need to reinvent the wheel. We have very effective medications. Actually, I would argue many of these medications, the medications we have, are more effective than many of the other common medications we use to treat other common illnesses. And in addiction treatment programs that now kind of are out there for people, 50% of them or less are actually offering life-saving treatment. And of those who do have it, only about 40% of patients in the program are being offered medications. And then in the medical community, about 5 to 6% of physicians are actually even waivered to prescribe one of the most readily available treatments that we have in the outpatient setting, which is buprenorphine, and we'll talk about that. This is an article by Nora Volka, who's the director of the National Institute of Drug Abuse, and she was responding, and her colleagues, that really, in order to get a handle on this crisis, as we have with any other crisis in the past, we have to go back to science. What we know is of the biology of this illness and of the medications that we have, and really, in order to do that, we will get a handle of this as we have in the past. And before we do that, it's really important to break down what addiction is. People have a lot of misconceptions about this as an illness versus a moral failing, versus many people think this is a manifestation of a psychiatric illness. And it's a primary illness of itself. It's a chronic brain disease that's characterized and underscored by ambivalence, which we'll describe, and by compulsive drug seeking despite really harmful consequences. So really continuing to seek out that drug despite all these horrible things happening to people. The other thing that's really important to know is it should be expected that people relapse. There are elements of relapse and remission, just like every other illness. And when people relapse, we need to respond accordingly with more support. And up to 50 to 60% of people's predisposition to develop this illness, they have zero control over. So it's the genes that they're born with put them at risk if they're exposed to a potential addictive substance. We know also there are environmental risk factors that contribute to people developing this. Adverse child events, we've heard a lot more about trauma, early exposure. Certainly when people's brains are developing, we know that our brains don't fully develop until we're kind of in our late 20s. And so if you think about the majority of people, majority of adolescents and young adults will experiment with drugs and alcohol before their brains are fully developed. And a subset, a portion of those who are exposed will go on and develop an addiction. And that early exposure can put them at risk. And lastly, while we're all here, we know that without treatment, there's a significant progression of illness and premature death. There's also this notion of choice. And certainly when people first try, when I was a teenager, I tried alcohol thinking that it was not a big deal. And I was a lucky one who didn't develop an addiction. But I had no kind of dream that I would, even thinking forward, become addicted. And for my patients, when they come in and I talk to them, when you were little, what did you want to be? What did you want to do? Not one of them said I wanted to be where I am right now. And so this notion that once people develop an addiction, they're still choosing to do this to themselves is really missing the mark of what happens biologically and neurochemically to people. And that's very important to go back to when we think about how we respond to people when they come to care. And one thing it's also important to go back to is what happens kind of on a very granular level to people when they're exposed to an opioid. So initially, when people take an opioid, whether it's to experiment, to feel good, to have fun, or to self-treat an untreated depression or anxiety and they find relief, they initially use it to feel good. And many people use drugs and alcohol to feel good. And I think many of us in the room probably have experienced that, or have had people who've experienced that and then can stop. What happens with opioids as they continue to use is that people actually go from feeling good to then needing to use to actually feel normal, to get out of bed in the morning, to get their kids to school, to get to work. And then they actually progress to now needing to use to not be so sick that they can't function. So there's this notion that people continue to use to get high, and that's actually written a lot, addicts getting high and using these very stigmatizing terms. And what they're actually doing is trying to use to actually bring back themselves to a normal function. And that's something we'll talk about with treatments. What we know, we're talking about what happens to the structure of people's brains, comparing it to other chronic relapsing illnesses. This is an image, the left horseshoe of this beautifully rainbow-colored heart. That's a normal functional image of how our heart should look, blood flow and function of the coronary muscle. And on the right is somebody who suffered a heart attack, and you can see there's disruption there and there's actually death to the heart tissue. On the right is this is the brain of somebody with a substance use disorder. And the left picture, that top part, is the front part of our brains that help us to make decisions. And it's often described as the yellow light of our brain. It lets us slow down, weigh the pros and cons of decisions, and help us to make higher level decisions. And it's brightly colored and functioning. And on the right, somebody who is suffering from an addiction, you see that there's much decreased function in that area. So there are brain functional changes, just like somebody who's suffered a heart attack. The difference, actually, let me just go back to this, is that on the diseased brain, unlike the death to the heart tissue, is actually we see recovery in the brain of people with addiction if they get the right treatment. And so here you can see on the left is the deeper portions of the brain where the natural hormone dopamine, where we get reward, that's our pleasure hormone, is normal, rainbow colored. In the middle, somebody with an addiction who's actually 1 month in recovery, it's still a diseased brain. There's not that rainbow color there. And then on the far right, we see recovery of that rainbow color after here in this picture at 14 months of abstinence. So if we look at this and we think about our treatment models, which are largely based on these short, as patients describe them, spin dries, detox, and at that 1 month abstinence, that brain is still deeply diseased, and expecting people to kind of get back and get their lives back, it's no wonder that people are continuing to relapse and struggle, whereas we start to see recovery at that 14 months. So that's thinking about our treatment models. In terms of outcomes, we know that outcomes are actually as good or if not better in some cases for people with opioid use disorder compared to other illnesses like hypertension, which is another chronic relapsing illness we treat regularly. On the left, we see before people are in treatment, we expect it to be poorly controlled. When they get treatment, it's in control, that low level, and when we remove treatment, it can relapse. And if you transpose that addiction treatment onto the hypertension, it's exactly the same picture. And so we see that, and this gets to that chronic relapsing model. So taking a step back when we say, well, then what is effective treatment for this? We have multiple approaches to this, just as we do for other illnesses, and it's really the same. This could be described for someone with heart disease or with diabetes. Pharmacotherapy or medications, we have 3 FDA-approved medications for opioid use disorder: methadone, buprenorphine, also known as Suboxone, and naltrexone, also known as Vivitrol, which we'll talk about a little bit. There are also psychosocial interventions, which can be very helpful for people and needs to be individualized. There's cognitive behavioral therapy, really skills-based treatment. There's something that we use all the time in every illness we treat called motivational enhancement or motivational interviewing that works on getting to that ambivalence, helping people to move along onto recovery. And then recovery supports, which I know that there are many recovery supports in the room. We have recovery coaches at Mass General that's been really transformative to our care, and that includes individual support versus 12-step versus other smart recovery, peer-based approach. There's kind of a Venn diagram here because not all one size fits all and not everybody needs all of these, but by and large in the crisis, the single most effective treatment we have to get people to break that cycle of using and stabilize is medication. And then there are certainly people who can do it without medication, but it's a very, very small proportion because the majority of people we're seeing who are presenting have severe disease, and so they will need a combination. One thing to know, that the WHO has come out and been very helpful in defining guidelines. And although we say the best approach really is medication plus some form of psychosocial support, medication should not be denied to somebody if they are, for whatever reason, not interested or able or willing to take the effective behavioral supports that are recommended. So this is actually very similar if anybody has known or happens to have diabetes. It's the same approach, looking at this illness through the lens of other chronic illnesses. We don't have a cure, but we have very effective treatment to help people get into remission. The goal for control of diabetes is to normalize the patient's glucose and to minimize the complications of poorly controlled diabetes, like ocular problems or vascular problems, for example. And every intervention for someone with diabetes is individualized and balances the competing priorities in their lives. Treatments include medication, lifestyle changes, potentially behavioral support, and regular monitoring for complications. So really the same approach. Medication treatment for opioid use disorder, we know, is effective in reducing drug use, reducing the risks to the public and infectious disease transmission, reduces criminal activity, the risk of overdose, reduces death, it increases treatment retention, and improves social functioning. It's cost effective, it's safe, and it saves lives. So hopefully we can demystify this as we move forward. When we look at the pharmacology, this is a really simple schematic to break down those 3 medications we have. And I think it's important. You're not expected to know all the pharmacology of it, but just have an understanding if you interact with somebody who's on medications. So on the left, we have the opioid effect, and then we have the log dose or the dose on the side. If you look at the red line, that's the full agonist methadone. What an agonist is it's a stimulator for the receptor in the brain where opioids bind. And whether that's Percocet or Vicodin or heroin or fentanyl, they bind to that same receptor, and they bind there and actually cause an opioid effect. So that would include relief, if you're giving it to somebody with an opioid use disorder of methadone, relief of painful withdrawal initially. As we move up on the dose, we're targeting what are called cravings, which is this severe drive, a craving, a psychological craving or drive for this substance that is reflective of those brain changes that occur with addiction. Methadone can be continued to dose. As you continue to go up on the dose, you can continue to get more opioid effect, and there can be, if it's not controlled closely, there can be overdose with methadone or sedation. But in general, the goal of methadone is it's an incredibly effective medication for getting people to stop using the opioid that they're addicted to and to stabilize and feel comfortable. The idea is they blunt the effect if somebody uses on top of that, blunt the euphoria. Partial agonist buprenorphine, that's Suboxone, is also a medication that binds to that opioid receptor, but it binds much more tightly, and it binds much partially to that receptor, so it's not as strong an opioid effect. So people actually who are taking Suboxone and are addicted to opioids are getting much less of an opioid effect than when they're using. It's also very long acting, so they're not having to dose themselves through the day as they were when they were struggling with fentanyl or heroin or what other opioid they're addicted to. And the thing that's important about this in terms of safety is you can see that line kind of flattens out. That's called a ceiling effect. So after a certain dose, the maximum dose, even if somebody takes 100 more pills or films of this, they're not going to get any more opioid effect. So it's an incredibly safe medication. It is extremely difficult to overdose on this medication. The only overdoses that we've seen in people with buprenorphine who have an opioid use disorder are on megadoses of intravenous benzodiazepine, which is another sedative medication, or if children or people who don't have an opioid use disorder get into it, and it has to be taken under the tongue. So this is an incredibly important take-home point. This is very safe. It's also important to know that every day that somebody takes this medication, because it's partially in those receptors, if somebody uses on top of it, uses fentanyl, their risk of overdosing is lower because those receptors are partially blocked by this opioid, this weaker opioid. Then on the bottom, that kind of flat line, the triangles, that's an antagonist naltrexone. It's also known in the injectable form as Vivitrol. And this is one that you've probably heard a lot about, the criminal justice system. It's another tool for us, but as you can see, there's no opioid effect. It binds to those receptors and basically blocks them. And even if people use on top of that, while it's in their system, they cannot get any opioid effect. However, the concern with this is we're trying to bring people's opioid, their natural kind of opioid, back to a normal playing field, so they're feeling normal. They're not feeling cravings to have to use. They're actually finding function back in their life and finding they're able to kind of take their drive away from continuing to try to treat themselves. What happens with naltrexone is as it wears off through the month, because they're not feeling any kind of opioid effect, and many people describe as the cravings still persist. They feel kind of blah, and they may not want to continue it, or the cravings come back as it wears off, and they know that they can actually use now because those receptors are open. And the problem with that is that their risk of overdosing is actually higher at that point than when they were struggling with the opioid use, because now we've totally taken away any kind of tolerance to them. So this is a medication that has to be really thoughtfully administered, and it's very difficult to start when someone is in the active throes of addiction. We'll talk about that. This is a schematic just to go over the receptors again. So we have on the left that full mu agonist, methadone, and then the other opioids we talked about. That receptor is fully filled by that green molecule is the opioid, and it it blocks that and it causes that opioid effect. In the middle is the partial opioid agonist. As you can see, the yellow, it's in there kind of, but there's some floating there. So if somebody tries to use on top of it, they're blocked, but they're actually feeling normal. And then on the right is the full blocker, the antagonist, naltrexone. It's completely blocked. Opioids can't get in there, but that safety concern. Just a couple more details. So agonist treatment in a methadone, with methadone or buprenorphine, the goal is to stabilize and cause kind of stop that in and out short-term needing to dose themselves so they get a stable dose of opioid and they're not intoxicated, they're not feeling withdrawal. And the most common effect we hear people say is, I feel normal. If you see somebody who's on buprenorphine who looks impaired or drug affected, and they have an opioid use disorder, it's not the buprenorphine. It's something else on board. So that's another thing. A lot of people think, oh, well, they're high, it must be the buprenorphine. The pharmacology of this medication is really remarkable. And it requires a waivered prescription or an opioid treatment program to administer. Methadone has to be administered for opioid use disorder and a federally regulated outpatient treatment program. And so that kind of speaks to stigma too. This is one illness we make people go outside of the medical community in highly structured setting to get their treatment. The aims of agonist maintenance actually are pretty simple: to reduce and eventually hopefully stop illicit drug use, but I want to underscore reducing it is important too, and the associated risk, and improving psychological and physical health. And then the antagonist treatment, as we said, Vivitrol, is significantly less stigma because there's no opioid in there and anyone can prescribe that. The goals of any therapy are really to stabilize and normalize those brain changes we talked about, establish what we call durable hedonic tone, that's a feeling of normalcy and feeling good, engaging in care, obviously in recovery, preventing disease as we talked about, and in order to do that, you have to achieve the appropriate dose. And so for treatment providers, one thing I would really encourage is if somebody is struggling on medication to really think, is the dose appropriate? I see many patients in my clinic who come in who have been completely subtherapeutically dosed, continue to struggle and are discharged from care, and really we needed to optimize the treatment. And it's not to see how fast we can taper people off. So we talked about the OD risk of buprenorphine, incredibly low. We talked about naltrexone. I just want to focus a little bit more on naltrexone. This is a medication, as I said, it's an important option that we have, but it is very difficult to get onto. People have to be 7 to 10 days off of all opioids. That includes Suboxone, if they're on Suboxone and they want to transition over. We talked about the increased risk of loss of tolerance and overdose, but that 7 to 10 days opioid-free in the outpatient setting is very difficult to manage. People often have ongoing cravings and have difficulty with getting that 7 to 10 days, and even if we try to get them into an inpatient setting to do that, often insurance will not cover the time to do that. There was a study that came out, and I'm sure I always get questions about this when I talk about this, about last year, called the XBOT study, and it said, buprenorphine and Vivitrol have the same outcomes. And it was really kind of misleading. This was patients who were in a voluntary detox, and they were randomized to daily buprenorphine or the Vivitrol monthly injection. And then they were followed for 24 weeks to assess what their relapse rate was. And that analysis that they reported was based on people who actually started the medication, not people who didn't. And we'll talk about that. And that showed no difference. But if you looked at this study, it was a special analysis that they did. They basically found that many people couldn't get onto the naltrexone. So if you looked at those studies, the outcomes were not the same. And actually, buprenorphine is much more effective because that could be started right away. And the vast majority of people who were randomized to start buprenorphine started versus only about half of the Vivitrol. So when you look at that, actually the relapse was higher on naltrexone and there were more overdoses in those who were randomized to the naltrexone versus the buprenorphine. That said, still a tool in the shed for the right patient, but buprenorphine in the outpatient setting is still the safer and easier first-line treatment, better engagement, fewer overdoses, and easier to start. And people who are chosen for antagonists or any medication should be first and foremost what the patient wants to do. That's where we start with anything in any medication evaluation. In general, people who have milder illness, a shorter degree of use, with a very high degree and motivation for full abstinence, or people who have been on an agonist, haven't been successful for whatever reason, and they want to try it, but they have to be educated about the safety concerns and how difficult it can be during that 1 week because of very high risk even getting onto it. Opioid agonists, to herald the safety here and the benefit. On the left, these are two studies that are, I think, really mind-blowing. So this is a study from Baltimore, Maryland, that showed really a reduction. The red line is a reduction in overdose deaths as we had increased access to, the blue line is methadone, the blue dotted line, and the green in 2002 and up of outpatient buprenorphine. And there was a 50% reduction in overdose deaths as we had increased access to care. On the right is a study from France where any prescriber could prescribe buprenorphine. They didn't need to go through these long waivers, and they had an 80% reduction in death. And so when you think about it, when we think of other medications that we have, these are really significant studies showing dramatic improvement in people living, and yet there's still so much misunderstanding and so much disagreement about this, even in treatment communities, or reticence to prescribe this. We also know the longer people wait for treatment, the higher risk they are of dying. And this was a study that showed people who are on a wait list for methadone were 10 times as likely to die. Opioid agonist treatment reduces recurrences. This was a study out of Massachusetts that basically the take home for this was patients who had no medications, the green line, and just had behavioral health had significantly more relapses and cost, and people who were put on buprenorphine and methadone, so you can see the line is pretty much flat in terms of their treatment over months and relapse rates. We also know, and this is important for treatment providers and for first responders to know, that early use and treatment is expected. The natural history of this illness, just like the natural history of somebody diagnosed with diabetes and absorbing the diagnosis, learning how to take insulin, wanting to take insulin, being ambivalent about doing that, changing their diet, can take time. So this study actually showed patients who were randomized, again, top line, no buprenorphine or methadone. The middle line was buprenorphine, Suboxone, and the black line, methadone. And as you can see in the beginning, when people started, they dropped. They started using less, but they were still using. So instead of 30 days of the month, they were using 5 days of the month. And the longer they stayed in care, the better they did. And as you can see, compared to the people who didn't get medication, the people who did get medication did significantly better. The vast majority were in remission. This question comes up, okay, great, you tell me about these medications, but how long are we going to keep them on? You know, now I have someone on here, and now what? Really, again, looking through the lens of other chronic illnesses, we say, as long as the patient's providing benefit. We're in the worst overdose death crisis our country has ever seen, and every single time somebody now uses fentanyl, every single one time, and patients use multiple times a day, because it's so volatile and we don't know what they're getting, they're at real risk of dying. So if we have a medication and people are functioning and living and doing well, just like if their sugar's controlled and their diabetes, we don't put an end point to it. We say however long it's providing benefit, unless they say, I don't want to be on it anymore. And then we have a conversation about that too, and we have these other tools we can talk about. But again, if we think about what we know, I generally say if I have a person who says, you're telling me the best outcome is if I'm on this indefinitely, that's hard to swallow, especially for a young person. So we'll have a conversation, say, let's get you on it, let's see how we can do the best setting, at least at minimum a year, and let's see how we can do to get you stabilized, and then we can talk about it. But at every point, if somebody says, I want to take it, we're going to still talk about making sure they're making an informed decision, and then we'll talk about other safer ways to transition them, hopefully onto something else if they don't want to take the agonist anymore. But it has to be continually reassessed and individualized. And I would say the most important piece for all of us in the room is to really demystify this and destigmatize this. Many of our patients have own internal stigma that they absorb from us about taking medication, educating them that it's okay. And often people will then say, I want to continue. I think I've said this, treatment needs to be ongoing. There's a very high risk of relapse. This is an important study. This is a randomized trial that you will see often in trainings, where they randomize patients to detoxification and counseling versus buprenorphine maintenance. The vast majority, 75% of people who got on maintenance were retained in treatment and were in remission versus 0 who were detoxed, and actually 20% of those died. And so this actually was done well before the advent of fentanyl. This was from 2003. So if you think now, again, the emergency, the urgency of getting people onto treatment. Detox is not treatment for those of you who are seeing patients, and this is easy to say. When you're a first responder and you see somebody who's overdosed and you bring them somewhere, and you find out the next day when you do follow-up they were sent to a detox, the piece I think that we can do is to work with our detoxification facilities to talk about turning them into stabilization units, because the relapse rate is so incredibly high and we're just setting people up to fail the minute they come out. This is a patient reflection from a clinic patient of mine who left a note saying, don't hate the addict, hate the disease, don't hate the person, hate the behavior. If it's hard to watch, imagine how hard it is to be living it. And so this is something looking through the eyes of a patient. We think about, this is why it's so remarkable when we see patients, I think, how resilient they are. They have this illness that's so relentless, and then our treatment system is really setting them up, and they keep coming back seeking care, and our system is not set to meet the natural history of this illness. Treatment can actually occur in pretty much any medical setting. This is a study that basically showed that buprenorphine or addiction treatment can be done very well in primary care, and it actually showed, compared to patients who were getting buprenorphine maintenance and in an outpatient setting behavioral intervention versus that with medical management and counseling with their own primary care physician, they actually did just as well. And it doesn't mean to say that people who, that behavioral interventions aren't helpful, but they're not necessary for everybody, and they can be done feasibly in primary care very well. And that's actually our model at our institutions and the goals. Hospitalized patient, this is actually out of our colleagues here. I'll just give Dr. Wally and colleagues a shout out, where hospitalized patients at Boston Medical Center who weren't even seeking care were offered medication in the hospital. They were initiated methadone and a referral to treatment, and 82% showed up for addiction care. That is remarkable in terms, and these were people who weren't initially treatment seeking. And then they took it a step further, they randomized people to initiate buprenorphine versus detox. And of those who were initiated buprenorphine, 72% entered treatment upon linkage and discharged from the hospital, versus about 12% who were just detox, so very meager. And these are studies, in the ED, our colleagues at Yale did a really landmark study that showed patients who were coming into the emergency room, which is another touch point where you all are bringing people in crisis, as a real opportunity, that those people who were started on buprenorphine versus those who were kind of given a referral to treatment, almost 80% engaged in treatment versus 37%. And there was fewer, a self-report of less use. Low threshold models, you'll hear that term a lot. What is low threshold? It's basically meeting people where they are. How can you start? What do you want to start with first? Flipping the traditional treatment model on its head, where we'd have people come in for a long intake with a behavioral assessment, waiting maybe till the doctor comes a few days later to maybe initiate medication, and then we have that very high risk period where we lose them. Then we say they're not ready for care, you've got to go back to the back of the line. This is starting people on medication first and foremost, and then backfilling that. And so we know in Canada, where they have a very evolved system, people can go to can get their methadone dispensed in a pharmacy. Here our treatment models are very, very regimented. People have to go every single day to get methadone. So if you're trying to take your kids to school or get to work, it's really a barrier to care. And so patients who are getting low threshold methadone had an almost 90% retention at 30 days. Significant reduction in heroin and in cocaine. So for people who are using multiple substances, in increased stable living situations. And then low threshold buprenorphine, this was actually our colleague colleagues in New York who actually administered buprenorphine in a syringe exchange program where people were coming in actively using and wanted care, and found that their patients did just as well as people who were in standard buprenorphine practices. So this can be done. I'm beating this to you. There's a very high mortality rate for untreated addiction, and if we discontinue treatment too soon, we see a high mortality rate. Prison-based medication, this is obviously important and high on the list of what we're trying to advocate to be done here in Massachusetts. These are our colleagues in Rhode Island who offered treatment not only for people who came to them on medication, but actually initiated treatment in the prison system, both methadone and buprenorphine. We know that the risk when people leave post-incarceration is up to 130 times the general population. And so they're offering all FDA-approved medications in the correctional facilities, and there's a 61% reduction in mortality with direct linkage to care. So really dramatic outcomes. So what about diversion? I'm here with police officers and providers. This comes up a lot too. Diversion, it happens, we see it. It is, as far as I'm concerned, and what the data shows us, it's a workaround to our access problem. The majority of people that I'm seeing come and they have interfaced with non-prescribed buprenorphine as a mode to treat themselves, and it's actually, in many cases, been very helpful to engage people in care. Not advocating to do this, but it's the reality. People are not using this to get high. If they want to get high, they're going to use full opioid agonists, going back to the pharmacology of this medication. So really the best way to decrease diversion is to increase access to care, and access to care needs to be low threshold care. So we could have multiple people wavered in these highly structured, very difficult to access treatment programs, but that's not going to meet the need or the severity of the illness. And we can do this with short prescriptions in clinic, close interval follow-up, checking toxicology, and open communication. Stigma, I think this is on everybody's tongue. The bullet on this, changing our language, our lexicon is critically important. It also extends to what we're talking about today, medication-assisted treatment. We want to try to move away from that terminology. Let's just call it treatment. Some people have said, let's call it medication for addiction treatment, since MAT is already out there. It implies kind of that it's a crutch, which we know it isn't. So I just want you to imagine sobriety after multiple detoxes, Section 35s, long-term programs, overdoses, and relapses. You achieve remission or sobriety. You're in counseling, maybe. You're engaged in a treatment community. You're eating and exercising. You're working or going to college. You have your family back, and you feel normal. This is fantastic, right? We would all want this. But you're prescribed a medication. You're told by your support network that you're not sober. You're trading one addiction for another or crutch. You're told you can't start to move through step work until you're off your medication. You can't speak at meetings or hold leadership position because you're prescribed a medication. And you're asked by your family, well-meaning family and sponsor, what dose you're on and when you're going to get off the medication, or why don't you just switch to Vivitrol. And so what this does is, for our patients who are in recovery and no longer meeting definition for addiction, right, that compulsive drug use and actively seeking out, these are people, this is the best case scenario. They don't want to share this. And not only does it do that, but it raises self-doubt, it alienates them. They often lead to discontinuation of medication, which can lead to relapse, overdose consequences, and death. And I have had many patients who have had this outcome. So my appeal would be, we need peer support for patients with this illness, and we need to work together, but we need to stop stigmatizing medication. This is an incredibly effective medication. We need to help support people in recovery, whatever pathway that takes. So just one thing, why this is not trading one addiction for another. Again, opioid treatment, taking a medication by a prescription, by a doctor or in a treatment program, you get a stable opioid level effect, you're feeling normal, there's no intoxication, there's no withdrawal. It requires us to be monitoring them. And the goals actually are to reduce or stop using. And so by definition, they don't have an active addiction at that point, they're in treatment. I'm going to skip over here so Dr. Wally can take over in a minute. One thing about relapses, I talked about this, we hear relapse is part of the recovery. It is not a failure. It should be expected, and it should always be reframed as a learning experience. I saw, I think it was something, a video, something heroin. It was really great. And there was a first responder who was wonderful. She went to the scene of an overdose, and she was so compassionate and was encouraging the patient. He had just gotten into treatment, and she handled it so well. Didn't demean the patient, emphasized that you're going to get better. And us being hopeful and positive is actually going to translate onto the patients and emphasize the hope even if they can't see it, because relapse happens, but we just have to reframe the treatment and retune it. Abstinence and harm reduction, it's a spectrum, and it can take time, as we talked about. And I'm going to leave you with harm reduction. It's a really dirty word in the addiction community, and it need not be, because anybody who provides medical care, and everybody in this room, provides harm reduction. You're giving Narcan out. That's a harm reduction intervention. Medical providers who manage people with diabetes and hypertension are providing that every single day when we teach people how to look at their foot to not have foot sores. It can happen anywhere. Engagement is a primary goal, trusting environment, balances risks and benefits. It's collaborative, and it's patient-centered care. Reducing the negative consequences, as I said, it includes safe injection practices. This is something also people kind of feel uncomfortable about. The traditional expectation is that people will kind of get it and be on the road to recovery, and it can take time. Narcan, this is from a patient, for those of you who are giving out repeated rounds of Narcan and saying, what's going on, is this futile? This is from a patient who had this first overdose after 20 years of IV drug use. He could describe his feelings and thoughts. He was saved. He was grateful. This drug is saving lives. Thank God. God bless. Keep the faith. The next day, it was his birthday. He's received the best present ever, another chance at life. So grateful for my family, for my health, for this program, and a grateful heart will never relapse. And of course, he relapsed, but he was engaged in care, and those relapses became shorter and fewer over time, and he's now in long-term remission. So for those of you who are saving people, on the other end, when we get to see people and we have the luxury of working with them, it works. Abstinence is not the only marker of recovery. As I said, medication can be given to people who are still struggling with other illnesses, and celebrating progress is crucial. I could go on and on, but I don't want to take the floor and give Alex some more time. I'd just like to leave you with this one reflection. I came here expecting the same old stuff, like doctors that look down or don't really help. I left amazed and overwhelmed by the amount of support I received. This place kept me from using, and every hospital should have a bridge clinic. It's a groundbreaking and life-saving clinic. This is not here to tout the Bridge Clinic. It is, as I said the other day, this is, I think, such a poignant message that a patient had to take the time to thank us for doing what we do for everyone else, and that this, hopefully, we will not see so many of these letters down the road, but this will be an expectation that people are treated with compassion, emergently, and with evidence-based treatment, and stick with them as they continue their pathway to recovery, as long as it may take.
So I'm going to pick up where she left off. I'm going to repeat a couple things that I think are kind of crucial, but I'm going to focus more on overdose, specifically why engagement after overdose is important. Now, I think you probably all understand it, but I'm going to give you a little bit of at least my perspective on that. Fostering help seeking after overdose. So Chief Allen and Chief Bodieri wanted me to talk about the Good Sam Law. I'm going to talk about that within this section. And then making spaces safer. So Dr. Kehoe, I think, sort of laid the table for some of that thought. I'm specifically going to bring up the issue of bathrooms, and I'm interested in what your all experiences are in the community. So why engagement is important. So after overdoses, few survivors receive medications for opioid use disorder. And so this is data that comes from Massachusetts, from the Chapter 55 data set. From 2012 to 2014, there were 17,755 individuals who went through, who had a non-fatal overdose, where they either were transported by the ambulance or arrived in an emergency department. And you can see that very few received medication. Doesn't show up, but that line right there, between 0 and 20%, is the number of people who receive medication. Actually, this is just to orient people. So this is where the overdose happens. This is the 12 months before the overdose happens, and this is the 12 months after the overdose happens, okay? And this is the proportion of people who get these 3 treatments that Dr. Kehoe just mentioned. So what I've just done here is increase the y-axis. So instead of going from 0 to 100%, it goes 0 to 10%. So now you can actually see better how many people are getting the medications. So some people are getting buprenorphine and methadone like 6% before they have their overdose. You can actually see a little dip there in how many people are getting buprenorphine and methadone, and that's probably because when people get taken off of these treatments, some of them overdose. Far fewer getting naltrexone because it hasn't been around as long. And then you see what happens after the overdose. And the amount of treatment actually goes up after an overdose. But remember this scale. We're still talking about less than 10% of people who've now had a non-fatal overdose, right? And we know there's a life-saving treatment. And their life has almost been taken from them. And they're not getting access, even in Massachusetts where we have insurance and we have reasonably good access to these treatments. So all in all, if you take all 12 months, 30% of people get at least 1 month of a medication. So that's starting to sound not, better. Okay, we'd like to get it really high, like close to 100%. And buprenorphine's the most popular. Then methadone, and then last is naltrexone. But this is a key point right here. The number of months out of those 12 that people are on that medication, it's far fewer than 12. With buprenorphine, it's 4. With methadone, it's 5. And with naltrexone, it's only 1 month. And that's really problematic, because as you saw with Dr. Kehoe's talk, I think she really laid out how now it's not just enough to be on the medication. For it to work, you got to take it, and then you got to stay on it. And that has serious implications, okay? So if you're on the medication, well, if you're not on the medication, 5 out of 100 people will be dead at 12 months after a non-fatal overdose, okay? That's a very high death rate. That's 1 out of 20 people. These are typically younger, otherwise healthy individuals, and that's a super high death rate. If you are on one of these medications, that death rate's cut by more than half. Okay, there's not much in medicine that we can do in a disease that's this fatal that is that effective. Now, this analysis assumes that you're on the medication. But what I just showed you was that people don't stay on the medication. And so we did a different analysis where we accounted for the fact that people come off the medication. So if I prescribe you a medicine, I have to think not only, okay, he's going to benefit while he's on the medicine, but if he goes off of the medication, his risk is actually going to go up. And so that's something we don't often put into the calculus, but epidemiologically it's really important. And in fact, because naltrexone, people don't stay on it, it completely erases the survival benefit of naltrexone. Okay, and it's because people don't stay on it, and when they go off of it, their overdose risk actually goes up rather than down. So just reiterating Dr. Kehoe's points, trying to really show that these medications are effective, it's not good enough just to start them. You have to stay on them. And it's hard, even in Massachusetts, for people to stay on them. And that's really where I'm trying to think about with medication now, is how do we get people on it and how do we keep people on it? The low barrier access methods that she talked about are key. Now, no matter what we do, not everybody's going to go on medication, okay? And so I'm going to transition here to thinking a little bit more about what do we do while we're waiting for people to start treatment, or what if people don't want treatment, or what if people can't access it. So this is Dan Bigg, this Chicago Recovery Alliance van, which is where he started passing out naloxone basically illegally in the late 90s, early 2000s to people who use drugs themselves. That really started the naloxone movement that we now see, okay? Now, we've come a long way, right? So now we have the American Medical Association, the American Pharmacists Association, the National Drug Control Strategy, American Society of Addiction Medicine, and the World Health Organization all endorsing naloxone distribution to first responders for sure. In fact, the 2013 National Drug Control Strategy featured Pat Glynn and the Quincy Police Department as really the trailblazers for bringing naloxone into law enforcement in fire departments. But also to people who use drugs and their loved ones. So this is now like mainstream, like really mainstream. Like the Surgeon General in April said explicitly that not just people who are using opioids themselves, but their social networks, their friends, family, their service providers should all be equipped with naloxone and know how to use it. Now, of course, you all know that, but I'm just laying out the case, and you're all doing this. Okay, so one of the issues, especially in a fentanyl zone where we are, is that while naloxone still works with fentanyl, fentanyl has really changed the dynamic. And one of the things that fentanyl, I think, shines a light on is how important it is to seek help. Because while naloxone is crucial, we also want to try to get people to seek help as much as possible at an overdose. So in the statewide naloxone distribution program, where I'm the medical director, and we distribute tens of thousands of naloxone kits through community-based organizations. So the one that is most active in Plymouth County is BAMSI out of Brockton, but we have them in all counties in Massachusetts. So when people get a naloxone kit and then they need another one, they come back to these programs. And when they come back to these programs, we collect information on what happened to the naloxone, okay? And that includes if the naloxone was used during a rescue. And if it was used during a rescue, we ask people, well, did you call for help or not? And so that's what this number is up here. This is the help-seeking rate. So you can see that it has gradually gone up over the course of the program from 30% up to basically 50% of the time. And so 50% is obviously a glass half empty, glass half full situation. But that progress is in the right direction. And part of it has to do, I think, very clearly with the enlightenment of public safety and sort of understanding this as a health crisis where, you know, people are more interested in calling for help. There's other, you know, and the Good Sam Law, which I'm going to talk about, which started in 2012, is one sign of that, right? Is where we're going to think of an overdose as a public health event rather than a crime scene. Rather than a crime scene. Another issue undoubtedly is the fentanyl surge, which started in 2013. It's a lot scarier to see a fentanyl overdose than it is to see a heroin or oxycodone overdose. And I think that really motivates people to call for help. There's other elements that we found that are associated with calling for help. So if the naloxone doesn't work, people are more likely to call for help. So we train people to call first and give naloxone next. But what we know really happens, despite all the training that we do and all the training that you do, and it's human nature, I would argue, is, you know, see if the naloxone works. If it's not working, then you're going to call for help, right? Because you're running out of things that are going to work. Being in a public setting, the reverse of that is if people are in private, they're less likely to call for help. And that's common sense also, right? Because who wants public safety coming into their home? There's this rescue survivor familiarity. So actually, the more likely I am to know somebody, the less likely I am to call for help. And then the year when it happens, so we're seeing that actually help seeking is going up over time. Okay, so why don't people always seek help? And I'm just going to reiterate some of the exact things that you saw Laura, and this gets to the fact addiction is a compulsive drive to take a drug despite severe adverse consequences. If people if people were motivated by, the adverse consequences, then we'd see a lot less addiction, right? We've tried negative reinforcement around the drug crisis for a long time, and it's clearly not enough, and I think in some cases, a lot of cases, it works against us. And so what we see from initial use, acute use, before people develop an addiction is that drive to feel good, and that reinforces itself so people use repetitively. But when you start using an opioid on a daily basis, you transition to a different phase where you're using to feel better or using not to be sick. And so that explains to me why when you do call for help and the person gets naloxone at the scene, they get transported to the emergency department, and now the naloxone's kicking in and they're starting to feel ill, they're starting to feel this sickness, their thought isn't, wow, I really need to get into treatment now, their immediate thought, and this is really like fundamental to the disease, is that I need to use opioids so that I won't be sick. And that's one of the reasons why we have a really hard time retaining people in the emergency department. And that's one of the big frustrations, I think, for public safety and public health mutually, is this, like, you know, trying to engage people at that time. But we can't give up. It's really important that we think of, you know, that we continue to innovate. And this program, the Plymouth County Outreach, is one of the programs that is really responding to this issue that we're having. Okay, so the Massachusetts Good Sam Law, I imagine a lot of you all know the details, but you know, it's actually been around now for over 6 years. The key portion is that a person who seeks medical assistance for someone else, or the person who's experiencing the overdose themselves, neither of them should be charged or prosecuted for drug possession, or, and this is the new part that just was revised in July, or found in violation of probation or parole. That's the new piece, okay, in 2018. That last, this part, I can't jump that high. That part right there, okay?
Yeah, you can.
Okay. So the rest of it's been around since 2012. Seeking assistance may be used as a mitigating factor in prosecution under the Controlled Substances Act. Now, that sounds like a prosecutor thing, right? Mitigation. Somebody can explain what mitigation is to me, but I think I know what it means. It means that they can take it into account if you save somebody, that the charge that you get won't be as severely prosecuted. However, and this is really big, does not prevent drug trafficking, distribution charges, or warrant checking. That's the hole in the Good Sam Law, okay? And some of the most experienced overdose rescuers, who are also some of the most experienced people who use drugs in your communities, also have warrants. And if they think that they're going to get run on a warrant, they're much less likely to stick around for when public safety comes. And so that issue isn't taken care of by this law. The other thing is what I call the footprint effect. So if somebody knows somebody whose name was run on a warrant and they ended up getting arrested at the scene of an overdose, you know, not for possession or not for possession, but for, you know, a warrant, then it feels to them just like they were arrested because of possession at the scene of an overdose. So that's really the sort of benefits and the limits of the Good Sam Law. Now, a lot of this is local discretion. Law enforcement has a lot of local discretion, and at least in my view as a non-law enforcement. But what I see across the state is the way that this law is handled is different in different communities. The amount of discretion that different law enforcement uses is different, and that's, I think, where relationship building with the community can be. The law also explicitly says it's okay for somebody to possess, receive, and administer naloxone if their intentions are good, which they usually are. So I mentioned, you know, I wanted to say a little bit more and dig in a little bit more on post-overdose public health, public safety partnerships. This is actually a descriptive study that we did. We included some of the communities in Plymouth County. Now this is old news. We did this back in 2016, which is over 2 years ago, when the post-overdose public health, public safety partnerships were first starting. And we described 4 different types. I think the most common now is the multidisciplinary team visit, which is where a public safety, public health go to the home of the overdose survivor or site of the overdose after the overdose happened, and they offer services. There's also programs that work just with police, where the police goes to the home and offers referral to community treatment. There's a clinician outreach where a clinician is embedded within the police department or with a community partner and does either phone or in-person outreach. And then there's the Gloucester model, which is really location-based outreach, where police stations or other places, and I think it's the Challenge program in Brockton, Champion program in Brockton. Okay, so there's all these models. You all are really innovators in this, and there's probably more models now, and I'm actually interested to hear about what they are, and I'll get into that in a second. Now, Dr. Keogh showed you a slide that's a version of this. This is the one we have at BMC, where every September at Boston Medical Center we ask staff and anyone else to sign a pledge that they're going to use non-stigmatizing language. But I want to mention this. So knock and talk. Yeah, so Chief Bodieri and Chief Allen, they don't like knock and talk. They think
Investigate them.
You know, I got to flip it. Sorry. I did this morning. It should be flipped. So,
You can't hear with that.
Knock and Talk should be here, and post-overdose outreach should be here. Okay? So, and so I just want to own up to this ongoing discussion about what's stigmatizing and non-stigmatizing language. And so I'm involved in, we applied for grant funding to do a study of the post-overdose outreach programs throughout the state, and I'm working closely with Chief Allen and Pari, and he was more than happy to participate, but he wanted me to change the language, and so we're doing that. And so instead of using the term knock and talk, we're using post-overdose outreach. There's problems with that. So if you, because of the acronym post-overdose outreach partnerships, doesn't work so well, right? So we had to come up, post-overdose outreach partnerships doesn't work so well. Nobody gets it. Nobody gets it. Post-overdose outreach partnerships, the acronym doesn't work so well. What does it spell? Okay. So we had to come up with something else. Pronto, which is post-overdose outreach, but it's not using, okay, the first letter of all the, okay, so, thank you. Okay, so here's what we're going to do over the next 3 years, and we hope that you all will be involved to some degree. So we're going to do a comprehensive inventory of these programs throughout the state, not just Plymouth. Like Plymouth County will be definitely set an example for the rest of the state, but we're going to look at those places that have really emerged throughout the state. Identify best practices, ideally using direct observation, where we're going to have people come and actually watch what happens during these encounters. We're going to try to determine the effectiveness, looking at municipality by municipality based on whether they have a program or not and key characteristics. And then we hope to end up with developing evidence-informed recommendations based on the findings from above and reviewing the literature. So I wanted to introduce that because you're going to hear more about it. I'm really excited about it. Okay, so and if you have questions or comments, I'd love to hear them. So making spaces safer, an example, bathrooms. So in 2016, we did a study of the 3 southeastern counties in Massachusetts. That's Barnstable, Bristol, and Plymouth. And we looked at the deaths that occurred in those counties, and then we went and talked to people who had ever either survived an overdose or who had witnessed an overdose. And during this time, you can see what happened to overdose deaths. So the dark blue is fentanyl, and we hit it right at the time where the death curve was really increasing as far as proportion of fentanyl deaths in those areas. And then we interviewed people, and we got quotes like this. So now what they are doing is they're cutting the heroin of fentanyl to make it stronger, and the dope is so strong with fentanyl in it that you get the whole dose of the fentanyl at once rather than being time released. And that's why people are dying, plain and simple. You know, they are doing the whole bag, and they don't realize that they can't handle it. Their body can't handle it. Okay, so fentanyl overdoses present acutely and severely. This is what we learned, again, from these 3 counties. I would say you notice it as soon as they are done. They don't even have time to pull the needle out, and they're on the ground. Now, I used to teach that that was just something you saw in the movies with heroin, okay? And that heroin overdose doesn't actually happen with somebody's needle in their arm. But with fentanyl, that does happen. So it has totally changed the ballgame. So overdoses have changed from a minutes to hours evolution to a seconds to minutes. And we heard this from many of the witnesses describe rapid overdose, immediate blue discoloration of lips, gurgling, body stiffening, or seizure-like activity. That's all kind of new to fentanyl. It's scary after you do a shot of fentanyl. You feel it, and it's like, oh crap, I'm going to overdose, and you're trying to say it, but it won't come out, and then you fall out. Okay. Evidence of rapid overdose among the people who died from fentanyl. 90% had no pulse upon EMS arrival. So most of the time, the people are already dead by the time the first responder gets there. 36%, now these are looking at death files, which is actually very difficult to figure out exactly what happened. But in over a third of them, it was clear that there was a rapid overdose, meaning that like they fell on top of the drug-using equipment, or the drug-using equipment was right there. That's totally new in the fentanyl era. That's not what we used to see. So here are some examples. And that was only the case in 18% of heroin-related overdoses. And this is really surprising. So on the one hand, 86% of overdoses occur in a home. Now, we often think of people out in the public, right? Like in the area of Boston Medical Center, we think that people are overdosing outside where everyone can see them. Well, actually, the great majority of overdoses happen in a home. And actually, 82% of the time, there was someone else present in the building when they overdosed. That was really surprising to me. However, lots of separation in the building. 72% were spatially separated, 15% were also using and likely impaired themselves, which is something I'm hearing about more often. 15% were presumed sleeping, 11% were presumed using the bathroom, which we'll get to. 11% reported signs of intoxication, but the overdose wasn't recognized, and only 10% of the time was the use actually witnessed. So even though there's people in the building, they're not watching each other, or no one's actually observing them. And on only one case of a fentanyl death was there a bystander present who was unimpaired and observed the drug use. So this is out of 200 or 150 overdoses. So it's very uncommon for somebody to be observed by somebody unimpaired and who could actually respond in a fast enough fashion. And the evidence of a layperson administering it only occurred 6% of the time, law enforcement administration only 5% of the time, and almost all of these people who got the layperson or the bystander or the first responder were already dead, right? So these are, it's good to give naloxone if somebody's unresponsive, but if they're already dead, it's not going to bring them back, okay? Okay, so here are the kind of bottom line that came out of this study that we did. First of all, fentanyl should be included on standard toxicology screens. It wasn't at that time. That's really aimed towards the medical field and the addiction field. Adapt existing harm reduction strategies, such as direct observation of anyone using an illicit opioid, ensuring bystanders are equipped with naloxone. You want enhanced access and linkage to medication for opioid use disorder. Okay, so this gets to, if people are going to use, where should they use? Okay, if we accept that people are going to use, if you're doing your post-overdose outreach and you're hoping you're going to get that person into treatment, you're doing everything you can, but you know that there's a good chance they're still going to use, how are you talking to them about where they're going to use? So Dr. Kehoe mentioned supervised injection facility or supervised consumption space. Those aren't legal. They don't exist in Massachusetts or in the United States. And it's possible they might come down the line, but not anytime soon, realistically, okay? There's a lot of issues with those, legally and politically. Now, I personally support them, but I think even if we were able to have them, they wouldn't be available to everybody, right? So then what do we do? Well, so this is a hierarchy of safe places from a person who uses drugs perspective, which I think is really helpful to think about, right? And it turns out that bathrooms are thought to be a safer place. They're clean, they're well lit, they're private. Multi-stall bathrooms, we know from our own hospital setting, are much safer than the single-stall bathrooms because someone else is likely to find you if you overdose in the bathroom. And we are seeing that quite commonly in our hospital. And then you can see, then there's actually people using with other people, which is what we counsel for people who aren't going to go into treatment. A communal injection site or a parking garage. And then least controlled is where people are isolated, and can't be found. So if these places are injection facilities, if they are places where people use, what are our options, right? And so one of the options is to shut the bathroom down. And that's happening, I think, in a lot. I mean, how many people have heard of that happening, where somebody shut a bathroom down, right? So, I mean, what would you do, right? If you have people overdosing in your bathroom, you don't want it happening on your watch where you are, if you're a restaurant or whatever. But, that's the reality of the world that we're living in. So, an alternative to shutting the bathroom down is trying to make your bathroom safer. Right, so here are some ideas. Make your bathroom safer by outfitting them with secure biohazard boxes where they can dispose of syringes. Now, most airports have this is from an airport, by the way, right? So it's not stigmatizing for people to put needle syringe boxes into their bathrooms. Good lighting with mirrors, doors that open out. We hear of a lot of overdoses where people are trapped behind the door. A call button with an intercom system, a reverse motion detector, which I'll talk about, and if there are safe injection equipment nearby, that's what a lot of the syringe service programs are doing, because they're having a lot of people overdosing in their bathrooms. And then naloxone rescue kits. Okay, here's a more detailed list, which I think hits on some of the same issues. Okay, one possible solution that we're doing actually at Boston Medical Center, this is something that requires an electrician, at this point I think it's early on, but it's something to think about that has been successful at Boston Healthcare for the Homeless, where they have a communal public bathroom that's used on a regular basis. They're single stalls. Is they include a reverse motion detector that's triggered by when the door closes and locks. Once the door is closed, it triggers this audible and visual alarm after 4 minutes of no movement within the bathroom. This has been utilized, as I was saying, at Boston Healthcare for the Homeless. We've just installed some as a quality improvement project at Boston Medical Center. At Boston Healthcare for the Homeless, they have 5 to 7 overdoses weekly in these bathrooms, and they've installed them in 4 public bathrooms over the last year and a half, 2 years, and they haven't had a single death. They have, it's what it's done is it's allowed the staff to monitor the bathroom without sitting there watching it the whole time. Okay, so this is what I hope to cover. Again, same theme that I think Dr. Kehoe hit on. I hope we have some time for some discussion and questions, and I really appreciate your time.
Thank you very much. Dr. Kehoe, if we could have you come up, and we'll definitely open the floor to questions. First of all, Dr. Wally, I learned from my public health leaders about stigma and language, and thank you for changing that title. See, we do make some headway between law enforcement and public health. That's awesome. Do we have any questions out on the floor? Anyone have a question? I'm going to hand the mic to you if you do. I'll start off with Dr. Wally, and I don't know that our outreach officers, recovery coaches, maybe realize, looking at the data, 50%. I've been wondering where that number came from, so now I have that slide. In Plymouth County, Sarah Ruiz had sent me, it's a little bit higher. 65% of users actually call 911, 85% of family members, but still, that's a real good number, because I think maybe, and I'll just speak for us in law enforcement, we probably assume that most overdoses are now reported, so I think that's a real good point. I mean, can you maybe just enlighten that a little bit more on that piece?
Yeah, it's good that you're tracking your own numbers locally, because there's dramatic variability across the state and from town to town. And I think one of the biggest drivers of that is relationships with law enforcement. And so the fact that if you're above 50%, that's I think really, that's a good sign. On the other hand, I don't think we're ever going to get to 100%. Honestly, it's, people don't want to ask for help unless they, feel like, they have no other option. And so, we actually, that slide went through 2016 and 2017. We've seen the numbers dip a little bit, and I think part of it is that some people are getting comfortable with managing fentanyl overdoses. So the other issue is that as people, like law enforcement and first responders, do their job in getting people to the emergency department, but once they're at the emergency department, we're really struggling with offering people something that really makes them feel better, honestly. So the emergency department traditionally hasn't been the best place for us to treat their withdrawal or get them into treatment. There are lots of efforts right now, specifically right now, to change that. Dr. Mendoza was just telling me that Beth Israel Plymouth got one of the HPC grants that's focused on beefing up the emergency department's ability to really treat opioid use disorder or initiate treatment, or really, what I think is the best model is to treat withdrawal in the emergency department and then hand off to a community resource, right, to get them engaged in a treatment program. Because realistically, people aren't going to always go to the emergency department for their treatment. We don't we don't really, we want people to come into our offices, right? But we need to figure out how to make it easier for people to come into our office.
And one thing just to piggyback, because we are doing it at Mass General now, our ED-initiated buprenorphine treatment is that we're trying to get them to say, don't hold people in after an OD and have them wait there and then wait to give them the medication, observe them. Just give them this short, we have a 2-day pack of buprenorphine. And to your point, Alex, they may not take it right then, they may use again, but that opportunity that they might, and the majority of the people based on the ED study, the Yale study, the majority are actually following up. So this very short pack of medication to give them to take home and then come up, so home induction, or if somebody's in the emergency room, they're having an abscess treated, or they're having something else, don't make them wait because they will leave against medical advice or they will use in the emergency room and overdose, et cetera. So to really just empower people to treat and be comfortable with that is a national movement.
We do have a question right over here. Am I standing up?
No, not at all. Actually, good morning, everyone. My name is Anne Marie Kennedy, and I'm the program director for ARCH at High Point, and ARCH stands for Addictions Recovery in Hospitals. And I just wanted to just add, I really didn't actually have a question. I just wanted to enlighten some of the community-supported services where we also partner and we attend the PCO meetings for the Plymouth County outside our research. One of the things that we do is we actually are heavily involved with Good Samaritan Hospital as well as the Brockton Hospital where they call for any overdoses. But our overdoses are not limited to or only involved with opiate, but late stages alcohol, and as fentanyl has been increased over the last year, actually, and this is just from Common Local. I'm not coming from a medical, I'm coming from a clinical perspective, and I'm also coming from a front line working with active addiction. So my statistics are not going to be as accurate and on point globally, but I'm talking in the neighborhood communities. So fentanyl is being laced on all types of different levels of substance use. So therefore, we're actually called, and a recovery coach is sent out to the hospital, and we try to do, main objective is obviously to get them engaged and to get them in treatment. But if I could just talk from the normal perspective, if everyone's okay with that, active addicts and addicts who are in early recovery, treatment is not what they want right after getting high. As a matter of fact, after they overdose, they want to know where they can get that other bag at because it was so potent. So what we try to do is we have recovery coaches coming in who have experience with years of recovery themselves and who have gone into treatment, and we introduce the medical assistant treatment program. You just, Doctor, I appreciate you mentioned that you guys don't like that to be said.
We only have about 5 minutes.
No, I just wanted to make everyone aware that we're in partnership with you guys, and we actually give them information where High Point happens to be one of the medical assistant treatment programs where we offer some outpatient where they can get Suboxone or maybe on the methadone or even the Vivitrol. If we're not able to get them right into treatment, we're able to hand them that information. So, you know, it's on the rise. We're connecting with you guys, and I'm going to attend more meetings so I can get more information. Thank you.
We have another
Thank
question.
you.
Behind it, the chief.
Yep. Yeah.
Hi, thank you. I was just wondering, the brain that you showed on the screen that was showing improvement after 14 months of abstinence, was that a brain that was with MAT assistance?
No, thank you. That was actually methamphetamine. That was a methamphetamine use disorder, but the idea is the general extrapolation is for use disorders. But the take-home message for that is that it takes time, and showing that recovery does happen for all substance use disorders and that our treatment needs to match the length. But no, that was not, we don't have medication for methamphetamine use disorder. But to your point, it's a polysubstance use crisis now, and many patients who are using fentanyl are actually very afraid to use fentanyl, and so they are using other substances. So that kind of narrative that people are seeking out the fentanyl clinically, I'm not hearing that as much. Early on, certainly that drives kind of the addiction, but many patients are afraid and are desperate to stop using that. So they're not overdosing, but may struggle with other substances. Yeah.
Hi, thank you very much. Great presentations. I mean, offers me a lot of hope. My question is more to Dr. Wally.
Yeah.
Can you give me and us an idea of where we're at with ED doctors initiating methadone in the ER, freezing the dose, and then doing a direct admit to a clinic?
Sure. So
Isn't that part of the CARE Act that?
Yeah, so all 3 medications are supposed to be offered. And you are speaking specifically about methadone. I've worked in a methadone program, so I'm familiar with how that works. And you also mentioned the term direct admission, which is a key innovation. So traditionally, methadone programs are separate from the rest of medical care, as Dr. Kehoe explained. There's this process actually where you have to go through an intake and wait oftentimes a week to see a doctor before you can actually start. You start at 30 milligrams. Both Mass General and Boston Medical Center have been initiating methadone for inpatients and then directly admitting them when they're discharged from the hospital.
You work with a colleague of mine.
Okay, great. And that is being taken up by more hospitals. But what that requires is a relationship between the hospital and the OTP. And those have to be created at this point in time, despite the law from this summer, program by program. We don't really have a system for that. We do it through relationships. It makes a lot of sense to do the same thing through an emergency department and or through a bridge clinic. So we both work in bridge clinics. We can't initiate methadone in a bridge clinic right now because of the laws, and we need to work on models on how to fix that. And part of it is like through relationships, where but there's a lot of hoops that we still have to jump through before we can do direct admission with methadone initiation. Unfortunately, and so I think what a lot of us are doing. And as a holding spot for that is giving people bridge buprenorphine prescriptions until that they can get into a methadone program. And it used to be that you had to have a so-called, well, I'll call it a positive urine when you went into the methadone program, or they wouldn't start you. But now we build the relationships where the methadone program will take them while they're actually, even if they're abstinent, but on our buprenorphine prescription.
And I have a question for Dr. Kehoe. The Bridge Clinic, why are we not seeing the Bridge Clinic in most hospitals? Is there a hesitation there? I mean, it's such a great model. It's evidence-based. It seems to be doing well.
Yeah.
Anything you can tell us on that?
Yeah, I think to your point, I think it's a novel approach in terms of addiction treatment. We just have to get the message out more that it's actually not a novel approach at all in terms of medical care. That's the irony. We have urgent care embedded in primary care. There's a doc of the day. If we had kind of every medical provider who was comfortable prescribing this, it doesn't need to be a freestanding bridge clinic at all. It could be just incorporated in any medical setting. So we need to keep empowering and advocating and validating. And I think mentorship and really kind of getting the word out with our colleagues that it's helpful. And it literally is, it's a walk-in clinic. People can come as they are, using or not. That's the other thing is I've worked in methadone as well, and in a formal addiction treatment center. It used to kill me where they'd say, well, he came back and he didn't come because he was high. And it's like, well, that's why he's here. Of course, how's he not going to? So just that, I think we just need to validate that.
Thank you.
Yeah.
Great. Well, thank you very much. Let's give the doctors a round here.
62% of those, the follow-up visit was warranted. And then we also have that variable of, is the follow-up visit then intended? So in some cases, we cannot do a follow-up visit. The person is homeless, we don't have an address, they live out of our jurisdiction, so it's not a Plymouth County event to follow up on. So of the 913 follow-up visits where they were warranted, 73% the visits were also intended. And again, our not intended reasons there: person homeless, didn't have an address to visit in Plymouth County, or the person had a warrant that required law enforcement attention, so we would not be sending a follow-up team out to that home. There were 910 attempted home visits, so multiple home visits can be attempted. That is jurisdictionally, the towns can decide what they want to do. If someone isn't there at the time, they can go back again and again. That is an individual town decision. So 910 attempted home visits were made. 60% were successful in reaching someone. That's either the person that overdosed, the family or friend that lives in the same residence, or both parties. So that's a very high success rate of having contact with someone. 39% of the successful home visits resulted in contact with the individual who had overdosed. 43% resulted in contact with family and friends. And then 18% resulted in contact with both the individual who overdosed and a family or friend that was present in the residence at the time. When we look at just those contacts that were successful in reaching the person that overdosed, these are our outcomes that we have. 42% of those, so there were 307 total outcomes where you spoke with the person that overdosed and or a family friend member, or not, and. 42% of those resulted in individual accepting treatment from the outreach team, so accepting a referral, in some cases accepting actual placement at that time. 26% or 80, the individual declined the treatment options provided. 19% they were already seeking treatment, so did not need those offered services. And 13% we still did not have a response entered in the database for 40 of those outcome visits. Which brings me to my first reminder for everybody, which is our follow-up outcomes. These are very, very critical outcome measures for our program, and it's the thing that everybody wants to know, well, what happens when you go to the home? So these are really critical for us. So I would just like to remind everyone, if you are speaking, if you meet up with the person that overdosed, please make sure one of these is a yes or a no. So the SUD accepted services, yes or no. SUD already seeking services, yes or no. SUD declined services, yes or no. Please don't leave all three blank if you actually met with the person that overdosed, because we need to clean up that data a bit. If you met with a family or friend or some other person that lives in the residence, please make sure you check either yes or no for whether that person accepted services. So these are really 4 very critical outcomes for us on that follow-up form, and we definitely appreciate your attention to those.
We would also add, we really worked hard to limit the data collection on the follow-ups. We really realized that it takes a big time commitment on your part to both do the follow-ups and then to be committed to the data entry. But please know that data entry is critical program outcome measures. We really have tried to limit down the data collection. So anything that you see there is data that we really believe are central to telling the story of what happens on these outreach visits. And we can tell you that the public health community is very interested in what's happening on these outreach visits. So it's really incumbent on us to collect that data to be able to tell our story.
So the next sort of new information we wanted to provide to you revolves around that at-risk category. And I think Chief Allen mentioned there's been a 106% increase. 103% increase in
We should start
at-risk.
trending that out, actually. We should we should start trending those out.
We don't, we haven't in the past, looked at that. We didn't expect it to ever rise to this level. But as the reputation of the program expands, more and more referrals are being made where a family or friend or another police department doesn't want to wait for this person to overdose, but they want to initiate this follow-up process before that happens. So this at-risk category is growing, and I think that's really a testament to the program and to the reputation and the good work that everyone is doing on the streets. So for that, we now realize, okay, this is a really separate category from a fatal or non-fatal, and we've made some changes to the database that will be rolled out this week. So the at-risk category, just to remind everybody, it's when someone, either a family friend, probation, house of correction, as Sean will mention, we are in different counties now, and one of those counties has a house of correction referral process when someone is reentering, or another PD identifies an individual who is at risk for overdose, and they want to initiate that follow-up process before an overdose occurs. If an out-of-county police department calls to report an overdose in their community, and that person lives in Plymouth County, so say someone overdoses in Braintree, and Braintree is really worried about this person. This person happens to live in East Bridgewater. So Braintree knows somebody in East Bridgewater, so they reach out, or maybe they know PCO, they know Vicky. They're gonna call and they're gonna say, hey, Johnny Jones lives in East Bridgewater. He overdosed here. We're really worried. Can you have East Bridgewater do a follow-up visit? That person should be entered as an at-risk individual in our system. The overdose didn't occur in Plymouth County, so we don't want to track it as an overdose. But we want to track that person as an at-risk. Someone has identified that person as at risk for overdose. So we want to track that, but we don't want that entered as an overdose. So East Bridgewater would then enter that as an at-risk individual in the system, and that would initiate the follow-up visit to the home while not double counting an overdose in our county that actually happened somewhere else.
Well, first, the first thing is it'll help tell the story of where are we getting these referrals from. If, as we're doing this over time, you have an idea for a category that we have missed,
Right.
please let us know. Again, we're trying to standardize data collection as much as we can. So if you have a suggestion, we get a lot of referrals from, one of the things that we don't have is a treatment provider. It's hard to imagine a treatment provider will call the police to make a referral, but maybe under some circumstances that happens. But if we're missing a category here, please let us know. We'll have a conversation with the advisory group to figure out if we should add those categories.
So then as we started to think more about this at-risk category, and we're getting more and more at-risk referrals, we started looking at the data that we were collecting and realizing some of these fields were not applicable to an at-risk individual, like hospital transported to. Well, if this is just an at-risk referral, there was no hospital involved. And so that really started to muddy our data around hospitals and Narcan administered. And so the change we're making this week are we're really going to limit the fields you have to enter for an at-risk individual to only those that are really appropriate for an at-risk individual. So you're not left saying, well, how am I supposed to answer this question? They didn't go to a hospital because someone just called me on the phone and referred this person. So how to answer some of these fields. When identifying someone at risk, the incident address should be the person's home address, so where they live. The incident date and incident time should be when you received that referral from whoever it came in from. So the day and the time that you initially received information that this person is at risk, put that in as the incident date and incident time. When you choose the at-risk category, there is a drop-down box. There's a blank field that has drop-down choices. Please fill those out. As Sean says, this is going to become more important as time goes on so we can see where are these referrals coming from. Right now, we have the choices of family friend, HOC or reentry, because that is what Essex County is doing, other government, and other. So other government could be a police department, could be probation, or just other. You can just choose that if it doesn't fit any of our categories. But again, if we're missing something there, please let us know and we can add those options. The opiate involvement field, we thought about taking that off, but then we realized for the individuals going out for that follow-up visit, that might be very important for them. What drug of choice is this person involved with? So we're leaving that, and then that should be either, if it's known, and choose the option known from the family friend or from the referral as to what drug that person is using. But definitely, it's not necessarily an opiate involvement in an overdose situation. It's just what that drug of choice is, again, if it's known.
And we're going to be sending these PowerPoints out.
Yes.
So, for many of you, you don't have a lot of at-risk referrals. So you can just refer back to the PowerPoint or these notes.
So I just wanted to point out, so this is your initial referral type when you're filling in the incident date, incident time, and then you're choosing that at-risk referral. And then you'll see the box underneath. You need to click in that box to get these drop-down choices, and then you just pick one of those drop-down choices. So you don't have to type anything into that box unless you want to if it's other, but you can just click in that box and there's those choices that we just mentioned. So I wanted to just point that out because some people choose at risk and then don't identify where that referral came from, and we really would love to start collecting that information more consistently. The other changes we're going to be taking off is the fields that are no longer going to be needed. So once you choose the at-risk category, you will not have to enter these fields or answer these fields. So the Narcan fields, Narcan administered, by whom, how much, all of that is going to go away and not be necessary. The hospital transport fields, hospital transport, a yes or no, which hospital, not going to be necessary. Or children at the scene, not 51A filed, not going to be necessary. The follow-up warranted and follow-up intended will automatically go to yes, because that's the whole purpose of an at-risk referral, to initiate this follow-up protocol. And then, so only your step 2 notification is necessary. And Sean's going to review our step 2, our notification process. Our step 2 notification is only to get that outreach team motivated and activated to go to see that person. So no step 1 is going to be needed. You'll just do a step 2 notification.
Just real quick, I mean, we were just talking with Sean, we're gonna probably want the children in 51, or at least the children in the home, only because with the grant that we're working with the DA's office on, that will definitely be information that would be something we wanna know.
So I think what we're going to do is we're going to leave the children associated with the person. Leave that
Okay.
one, but children at the scene,
I got you. Okay.
we're gonna say no, and the 51A filed is sort of because of an incident, so we're gonna take that one out. But yeah, we definitely thought about that. So you'll still have to answer, are children associated with this individual, yes or no? And you'll see that screen in a second. But those children at the scene, because those sort of questions seemed to not really be applicable for at-risk. So all these changes, I think we'll probably roll them out Wednesday, Thursday, Friday, somewhere along the way this week. If you enter an at-risk, you're going to see these changes. So we didn't want anybody to be worried that something was wrong with the system and all of a sudden you didn't have to answer all these other questions. Just quick other reminders about, and Chief Allen just mentioned it, about the children variables and about the mental health background variables. They have become very critical to us because of other grant funding that individual departments and the county has received for 2019. And a lot of people are asking and looking to PCO to supply data on these fields. So we just want to remind everybody, children present at the scene of an overdose is here, and then the next one over to the right, school-age children associated with the incident. So the children present at the scene and the 51A files will not be necessary for the at-risk, but we're still going to leave that school-age children associated with the person as something you'll enter for all overdoses and at-risk. And that is because of a drug endangered
So the DA's
children.
office, Melinda Nealon's here from the United Way, they've partnered up on they also got a BJA grant where one of the things that the DA's been rolling out to all the communities in the counties, 7 of us as a pilot have had, is children exposed, drug endangered children exposed to trauma, the ACEs study, adverse childhood experiences. So that's going to be a piece that we're going to be looking to capture, so we don't have to create a whole nother database to capture all that countywide. So that'll be a training piece, and like Chief Pateri just said, that's something not only that we have to do with our data designees, outreach teams, but get back to the patrolmen. There's going to be training that's going to be covered under this federal grant to train all the departments on that as well.
Right, so really critical field. Most of the time these are left blank. They're not mandatory fields or they're no. So really just, maybe put a little more thought into, does this person have children at home? More children at the scene, and try and make sure that those are filled out. As we said, we do need to start reporting all of that. The other field that is also associated with new grant funding is the mental health background field. And this is on the first slide of the follow-up outcome visits. So you'll see our follow-up outcomes, accepted services, seeking services. At the bottom of that first screen, we have that mental health background, yes, no, or unknown. Again, most of the time it's left blank or it's an unknown. If more effort can be made, and I know that's difficult, but we're just trying to remind people that it is there, and if you can, fill that out. If it's a parent or you ask a family member if there is any mental health background for the individual. That's really important for us to know. I know many towns, how many towns in Plymouth County?
So
have
5
mental
are piling down our way in the southern part. Duxbury's got a great program up there. Just so you know, there's a future funding opportunity that may present itself to Plymouth County Outreach that this is data we're gonna really need to help you have. I know I told Dr. Wally that our mental health calls for service are about 4 times or more than our overdoses in my community. I'm sure it's the same across the county.
We're probably gonna end up looking at those closely, the mental health piece and the children at the scene, and maybe making them mandatory in order to get the answer to them. So I think that's something to look at soon.
Right, we could do that once we, do a little bit more training, then we can make them mandatory, absolutely. All right, I'm gonna turn it over to Sean.
Okay.
I think you have a question, Lieutenant?
Yeah, Lieutenant.
So start.
Oh, yeah, sure.
We just promoted him.
Yeah, there you go, promotion, take it.
Someday again. Well, because we're trying to capture that data on the school-age children, if we're gonna make it mandatory, definitely, maybe we should make an unknown category. Because if we're getting these people and they're overdosing in a car, a parking lot, or a bathroom, we don't really have that background, so I don't think we wanna capture inaccurate data. So, I mean, especially if we're gonna make it mandatory, I think we should have an unknown field on that one. But it might not hurt just to have that anyway. In case we don't have the information, like our data entry is done, no, not at the time of the overdose, but shortly thereafter, so sometimes we don't have that full, complete report yet.
Great, we'll make that change to this week with that, thank you.
Any other brief comments or questions? Yes, sir. It's a great question.
We need to capture that, so how do we do that?
Well, so, I mean, I think that is really hard. And again, so there's part where we're trying to standardize the data collection at certain reference points. So part of me says I would prefer not to have it done because at the point of the follow-up visit itself, that was the best idea we have as to what happened. Another possibility, and first, the first thing is the question is the most important part. So we really appreciate you raising that question. One idea is we could possibly do a second follow-up. And even if you don't go do the follow-up visit itself, but what I would say is that I think we should entertain that issue as a group. Maybe we have, as the advisory group, a preliminary conversation, how to handle that. And then we have a recommendation for moving forward. I mean, Pam, do you have any?
Yeah, no, we have to capture that.
Right, that it becomes important.
That, Dr. Carroll, that partners up with DPA.
We could call it a second engagement, no matter how you got it, whether you heard it through another clinician or a recovery coach, but we're gonna have to capture, we'll have to talk.
We'll have to figure out a way.
Right.
Pam, did you have any thoughts? And I knew Vicki had some.
I think that, I think for the initial screen, the initial follow-up visit, we want to leave that, but potentially another screen that is about future notifications, and so that we can capture that somehow, but not go through a whole big, data entry piece. But I think we need to capture it. We probably just have to have more conversation about what's the best way to do that.
Couple of different ways we
Easiest way
could
to
do.
do that for everybody.
Make it a secondary contact or something.
We might.
Yeah, secondary contact, something.
There's something we can. I mean, there's a variety of ways that we can do it. But I think that's a great point, and we
need
have
to-
no way to directly reflect that today. Vicki, did you have a?
Yeah, I was just gonna say, I have been telling people to do that when people reach out after the fact to say, hey, I ended up going here, or whatever the case may be. I need to tell them to go back in and
Update it?
document it as another.
Okay.
additional.
Okay,
Okay.
great. All right,
I
good.
just didn't want to cause
Yeah.
any confusion where I've been telling people.
Yeah.
No, that's awesome. That's awesome.
So we're just going to clarify the notification process built into the database, and just for those people that don't know, one of the many layers of the novelty or the importance of the data system itself is that the data system enables communication between police department to police department, police to our hospital partners, and police to the outreach teams. So we have a built-in communication process that allows all of this program level communication and coordination to happen. So when we talk about the notification system here, that's what we're talking about, okay? So these are some screenshots of the database itself. And what we really want to do is to clarify both how the notification system should work, and with the at-risk category, we will not be doing the actual step one. So on the step one, there's two-step process to determine the eligibility for an outreach visit and to actually to coordinate the outreach visit itself. So the step one is after the incident has been entered into the system. The police department goes in, selects the step one. There's 3 groups of people that are automatically carbon copied on this email. Now we manage all that on the back end. It's the police officers in the department where the incident occurred. It's the police officers in the jurisdiction where the person lives. And it's key hospital partners in each of the participating hospitals. Now, there's a couple of reasons why that's important. Part of the PCO model is the resident jurisdiction, the police department where the person lives, is the police department that's accountable for doing the follow-up visit, right? So we have to bring them into the communication system. Then it becomes important for us to communicate to our hospital partners that a person has been transported to their hospital, and can they communicate back to us if a follow-up visit is warranted or not. Now, just to remind us, our hospital partners are our best partners in the project. They are well versed on how to handle this. They don't give us any medically relevant information back. They respond to us with 1 or 2 phrases: follow-up warranted or follow-up not warranted. That's all they tell us. That's literally the phrase that we get back. But that step one is critically important. If we don't send that step one, the hospital partners don't have an ability to query their systems to tell us whether we should do the outreach visit or not. We only do the outreach visits in 40% or 50% of all overdose events. That means for about half of our overdose events, the person was admitted into treatment at the hospital. They are medically admitted or they're admitted into treatment. We don't really know what happens to them because it's not the concern of the police. All we know is that we should not be doing that outreach visit because they have access to care already. All right? So that step one becomes important. It's our understanding that some jurisdictions are not sending out this step one. So that becomes important to make sure that resident police, incident police, and our hospital partners are all bought into communication that this event occurred and make a determination whether an outreach visit is necessary. Okay, does that make sense? Once we get that notification back from the hospital, and I have to give kudos to the hospital folks here, Sarah and Lisa and Steve from South Shore. I would say the time lapse between when this is sent out and the information we get back from the hospitals, I dare say is usually minutes, occasionally seconds. I don't really know how they actually get access to their computer and get a response back so quickly. We get email responses at 12 o'clock at night on a Saturday. So our hospital partners at the table have shown such a commitment to giving us that real-time information that allows you all to schedule those outreach visits as quickly as you can. So the hospital partners, we don't really know what we would do without you. Once that notification then gets sent out and the hospital partners reply back, the incident jurisdiction then has to go back and update the database. Is follow-up required? Is follow-up warranted? And is follow-up intended? Pam had discussed those earlier. There's times when this incident is eligible for a follow-up, but you all have made the decision you're not going to do it. There's a variety of program reasons, okay? Once you determine that a follow-up is warranted and intended, you then have to go and mobilize the outreach teams. And that becomes the step two, all right? That, step two automatically, again, sends an email out to the incident jurisdiction, the resident jurisdiction, and our outreach teams. All right, those outreach teams, we have 2 regional outreach teams. We have a north and south. that email automatically mobilizes them. So what we're finding is that there's certain communities or at times things you'll fall through the cracks where either the step 1 or the step 2 is not sent out. That becomes really important because we're finding that part of our outreach teams are not getting notified that they need to do these outreach visits, and we have individual officers that are periodically or occasionally kind of emailing people on the side. We really want to standardize and make sure that these outreach visits are happening as planned and that we're getting quick access to that, and our outreach teams are part of the communication. Okay? Any questions, about that? We manage the outreach teams, so as team members come in and out of this project, you notify Vicki, we'll add new members to the outreach groups, we will pull people out, we will do whatever we have to manage on the back end to minimize the communication and to only send that information to the people that need to get it. Okay? So just so you know, once you click step 1 and your step 2, and I apologize, this illustration is not necessarily the best, and the formatting of the print is not necessarily the best. But the system itself self-populates the emails. So all that work you did on the data entry, it automatically pulls that data over, and it communicates only the most relevant pieces of information, including, I'm sorry that my little, including the hospital where the person was transported to. So Lisa Harrington in Brockton Hospital can then go in her system, query what the treatment status of the client is to let us know whether follow-up was warranted or not. So we try to minimize, laser focus the communication, laser focus the pieces of information that are needed just to do the core work itself, okay? This is an example of the step 2. And again, in Plymouth County, we have 2 regional outreach teams. We have a north and south. So when you come in, when you go to send the step 2, it's the resident jurisdiction that determines whether it's the north or south, okay? And so we have those regional teams. Again, just trying to minimize the data collection, but also the communication, but the communication is really important. We don't get these step 1 and step 2 sent out in a timely way, then we're really hampering our ability as a county, as a project to work as intended. Any questions about the follow-up process, if there's been any confusion or problems? Another thing is, just to show you really quick, you'll also see this button down here. If for some reason you want to just email somebody in another department to communicate something either about an incident or just about life, but you don't necessarily know. I know Chief Pateri often just emails me about life. But let's say you don't know who the point person is. If you click that button, it will bring up all the staff associated with the project in that agency. You can send an email to everybody that's associated within that agency, or you can just send it to particular people. So again, we're really trying to close the loops on the communication system itself. One of the things, just so we know, we're steering away from collecting medically relevant data. Yep. Okay, so we just want to be clear. Certain data points we have explicitly not collected because we don't want to venture into data collection that we are legally prohibited from collecting. So there's times where we use what sound to be generic or bureaucratic terms. Please know that it's intentional, that we know it, but we're trying to collect data that helps us tell the story without getting into data collection that triggers HIPAA or other federal regulations about substance abuse data.
Sean, real quick, we've got 6 windows. SUD already accessing services.
This is if follow-up is not warranted?
Yeah, no,
okay, follow-up is not warranted.
SUD arrested, SUD deceased, section 35, incident occurred before the program start date or other.
So the follow-up not warranted, the majority of those are going to be because the hospital tells us it's not warranted. If the hospital tells us it's not warranted, then we assume they're accessing treatment. And the majority of the time, we're not going to do the follow-up visit because they were either medically admitted or they've been they were transferred from the ED or the hospital to treatment. I mean, those are really 90, 95, 98% of the reasons why we're not doing the visit. Occasionally, the person passes away after, or for other reasons, they have a warrant or other I can't remember whatever the other reasons were. Okay, so just to give you the heads up, we are going to be rolling out a complete redesign of the database January, February of 2019. We hope that we know that the new launch will take care of a lot of the performance issues that some of you had. As you can see, Sergeant Vecchi, who gets real frustrated when certain fields, the data doesn't collect and it times out. The original system, as we had planned, was never really designed to be a web-based, so we're really now redesigning it with new technology. So by 2019, the SIM system will be live in 3 counties. Plymouth County was certainly the first. We are in Essex County, and Norfolk County will be coming on in 2019. So we are, again, bringing in a complete new rollout of the database to take into account a lot of the concerns and frustrations and performance issues that folks have had. One of the big issues is the performance issues using the system over the web. That will absolutely be accounted for. Those people that purchase the iPad, you will obviously still be able to use the system. You just won't necessarily have to be beholden to the FileMaker app. So you will definitely see the system performs a lot better. We also are going to be cleaning up some of the business process issues that have just created unnecessary work. One of the things that we are going to do is we're going to allow for individual outreach people to be associated with particular agencies versus groups of agencies. So let's say you are a recovery coach that only works with Situate. Right? We can only have we can have it so you only get those step 2 outreach visits for Situate. So it'll kind of limit the number of communications that certain folks get. We're also going to change it for those hospital folks here, where you won't get, unless you want. Now again, I have to think, because Sarah might want them all, where you don't get all step 1 emails, but you only get those where the person was transported to your hospital. Now that I just kind of, as soon as I saw Sarah, I realized she probably likes more information than less. So that's confusing for me now, Sarah, thanks. But just to try to limit the emails that are just not relevant or necessary to certain folks. We're also going to create greater flexibility to customize some of these drop-down boxes. So as folks, well, we should add this and try out this. From our end, we can do that really on the fly versus going to a developer and all that kind of stuff. So what we anticipate is you'll find that the system performs better, carries out the core functionality, and will just be a smoother way for you to interface. So, any questions about any of that?
We will be scheduling another meeting like this for our data designees to roll it out when it comes. The questions are all going to be the same. The variables are all going to be the same. It's just going to look very different. Not very different, but different. It looks really nice. We're really happy with it, and we think you will be too. So we're not just going to spring it on you. We'll do a training first, and we'll get everybody comfortable with it, and then we'll bring this one down, and we'll bring the other one up, and you'll be transferred.
That's all we have. Any questions? Yes, Sergeant.
Last year we did a data scrub. We planning to do that again, or is the changes we made kind of resolve those issues?
We want somebody that wants to go back and clean old data. I love this.
I love it.
Chief Lettieri just said Sergeant Becky did that.
Yeah.
As we do the annual report in January, I'll be reaching out to people if I find issues, but the making things mandatory and cleaning up definitions and all of that has definitely helped. But I'm sure there are going to be a few emails I'll have to send out to people when we're doing the annual report.
Just one more, I know everybody keeps me asking
Yeah.
questions, but the survey stuff, have we seen it, do we know what the response to the surveys have been?
So
That's in the
that's
next
going to be
section.
next on our
Yeah, I think
agenda.
Vicky's going to talk about that.
No, that's great.
So just 2 things I'm going to hit on. Thank you very much, Sean and Pam. With the thank you. two things, and then we're going to have Vicki, we're going to give her out of here very quickly, but warrant and probation checks. I know, so Dr. Wally brought up a point about warrant checks and how that can have an unintended negative consequence. You know, again, we've always said, you know, there's an advisory board, Chief, correct me if I'm wrong, that we leave it up to each department to handle that. But again, it's just something for us to now think about. Probation, you know, we've talked about having that notification for that communication. I mean, I didn't know it, and neither did Chief Pateri. We talked about the probation cannot violate under the Good Samaritan law under that new overdose. So that was something new for us to be aware of. The other thing is classification of the opioid, the overdose. Most of them say in our database heroin. As all the stats show, almost none of our overdoses are caused by heroin. There's really no heroin on the street per se. It's all fentanyl, and I know we're not chemists, and I think we just got in that habit, but it's something to think about going forward, because when you look at the state data that says 80% or higher of all overdoses, or at least the deaths, are caused by fentanyl, almost, I would say, argue all of that is similar on the non-fatal. So just something to think about. I know we're not testing stuff at scenes, but you know, we want to have that data accurately reflect what's going on.
The only other piece I want to talk about is, Pam and Sean talked about that. I think you said 19% of that follow-up result screens are not being done. We need to go back and do those. We need to. That's important to have. Is there any way you can send out an email to the departments that need that, and then we'll follow up? It's important that we do that, so we got to check ours as well. So, does someone have a question over there?
Hi, Kathy Dryman, health agent for Halifax. I didn't think I'd have the opportunity to ask this question, but I think the opportunity just came up. When trying to have correct data on the cause of the death, there's a lag as the medical examiner looks into that. So I was wondering how often the police departments check in with the amended death certificate. So
You want to do that, Scott? Yeah, yeah. We've.
Actually, Sean and Pam, we're actually meeting on the 20th. Hillary DeBar and her team are doing an annual review of all the death certificates, but.
Yeah, great question, and it's going to be a project for 2019 for us to make sure that we are getting that updated information from the death certificate. So as the chief said, we already have a meeting scheduled on the books, and that's going to be part of the project we're doing for that following grant in 2019 that we just talked about, trying to reconcile the death certificate information with our fatal overdoses, because we know there's a disconnect there. So we're going to be working on that. That's a great question, and we're.
If you don't know, say if the death occurred in falls, they still might not know. It would still be unknown, the cause, and then in the beginning of the following year, it might be amended by then.
Right, and we don't, I mean, what we collect in the system is just a fatal overdose or not. We don't collect and the opiate if it's known. So we will be able to update those things with the death certificate once we figure out what that process looks like. But as you said, the death certificate data can be years behind in some cases. So we're going to be working on that and trying to figure that out. Thank you.
Okay, thanks. So we're going to have Vicki, coordinators, Vicki and Hannah, come up now and talk about some success stories and a few other things. You ready?
So just briefly, we wanted to touch upon the survey packets, which doesn't affect everyone. We're just doing it in 9 towns. We haven't gotten back any responses, so we just wanted to make sure that everyone was giving out those packets at the follow-up visits. These packets should be given out to the families and the person overdosing, and we really just want to, let them know that we're trying to get feedback on how we're doing. The police aren't involved in this. That Roger Williams is.
So what we started to do was last, I guess this past fall, one of the questions we continually get from our public health folks and the treatment people are, what is the impact of the outreach visits themselves, right? And really important policy question, what are you actually doing? And this access to care question, when you do the outreach visits, are you actually engaging people in treatment post follow-up visit? And of course, that's kind of the holy grail, right? It's a really hard thing to measure. We don't want police following up with treatment providers, and even if police could and would, the treatment providers were not going to give that information to the police. So it's kind of this circular conversation about how do you track this kind of stuff. So we're piloting something that we just started. So what we have is a standardized outreach packet. When the teams go out to the post-overdose follow-up visits, they have a resource pack that they give out. One of the things that we started to do was to adhere a mailing label on the back of it that says, "You matter to us. Please help us help you." And what we've done is Roger Williams University is doing a follow-up, well, really it's Pam and I, are doing a follow-up of these outreach visits. And what we're doing is we're asking people to text us. And when they text us, we will respond to them with a follow-up survey, which is an anonymous survey that asks them how they felt treated by the outreach teams, that confirms with them they got outreach information, and also asks them to self-report to us what kind of care or services they have accessed as a result of the follow-up visit. So we're trying to tell that story by getting it directly from those people. We're not calling them at home, which can be very confrontational. We're letting them do it on their time and if they're comfortable. So we're really trying to do it on their terms versus our terms. In the last 2 months that we've rolled these out, we have had 0 people. Okay, so from a methodology perspective, it's amounting to a colossal fail. So what we really do need is we ask the outreach teams, when you hand out the packets and these stickers are on back, please encourage people, and we're trying to get the language down that you really matter to us. And it's important that we know how we're doing. It's important to stress that the police have no involvement in these phone numbers, in the collection of the data. This is done by an outside group to create distance between you and the police. But it's really, it's really important that the outreach team stress to these clients why this is important. We really need to be able to tell our story. So if we just ask you that you really help to push the conversation on this, you encourage those individuals suffering with substance use disorder and their family and friends. One of the things that's really important, our program model sees the SUDs themselves, but also their family and friends as uniquely important clients of the outreach visits. So any questions about that? You'll see these stickers on the outreach packets. We really ask that you do your best to encourage people to take them. Okay, thank you.
The only other thing that I wanted to mention about these is it gives you a phone number to text, but it doesn't say what to text to the number. So that could be a barrier. So I've just been telling everyone to have them text the word survey to that phone number, if that works.
And then we will reply with a hyperlink to the anonymous survey itself.
The towns that we're doing this in is Abington, Carver, East Bridgewater, Whitman, Pembroke, Plymouth. Did I name all of them? Okay, so if you're from one of those departments and you don't have these packets, let me know and we can make sure that you get them. And then the only other thing that I wanted to touch upon, which we kind of already did, were the recovery coaches reaching out to the departments after the fact if someone is to contact you 2 weeks later or a week later, just reaching out to either me or that department to let them know so that they can go back in and document that. And then I've also reached out to a few departments so far, but I will be reaching out to all of you guys with a group of your high-risk overdosers. We want to follow up with them, and if we haven't seen them in our system in a while, we want to see how they're doing. If they need more services or if they're doing well, we want to be able to document that too.
As some of you guys know, I've been working on compiling some PCO-related success stories from data designees, outreach officers, and recovery coaches, because there is a lot of great work being done by you guys, and we really want to highlight that. We're going to be compiling them into something bigger soon. So I just wanted to share one quick success story with you, and just note, there is no criteria for a success story. It doesn't have to be getting someone into treatment. It can be finally having someone let you into their home after they've slammed the door in your face. It can be someone following up with you, after you talk to them and it's been a month, 2 months. So just don't think that getting someone into treatment is the only way to have a success. So Duxbury Police responded to a family problem in which a mother was having problems with her daughter related to heroin use, and they were going to enter her as an at-risk referral. And then the individual actually came and said she wanted help. So they arranged to get her a bed, and then the mother actually reached out and they got her services as well. So that's helping the individual and the family. And successes can be just making connections with the family and getting them services, and maybe they can help the individual get into treatment or seek services. So if you want, you can send those my way. There's no time limit, there's no deadline. Whenever you get them, whenever you process them, just send them over to my email or Vicky's and she can send them my way. Thank you guys.
So we've got about 5 minutes here. Obviously, the training was geared on medically assisted treatment, so we're going to have Sarah Cloud from BID Plymouth, you know, the point person here on PCO, talk a little bit, and then we'll get going.
Thank you. I know everyone's in a rush to head out for the day, so I really appreciate your staying for an extra couple of minutes. As a healthcare provider, I was actually very alarmed to hear that 90% of the folks who have struggling with addiction aren't receiving evidence-based treatment. So I really want to make sure that you're well aware of what resources we have available in our community. I think in the next upcoming calendar year, in 2019, we're going to see a lot of medicated assisted treatment become available in our emergency rooms. I know St. Luke's going to probably launch first before us, but then Beth Israel and Plymouth will come online probably in March, so we're going to get that more information out, and a lot of others, emergency rooms, are all talking about how to make this work, and our Mass Hospital Association is providing a tremendous amount of guidance through a work group that we are participating on with Dr. Mendoza, who just had to leave, so that we can get out a standard of care across all of our emergency rooms, and I hope that by 2020, we'll have a very different discussion and conversation about the treatment that's available in the community for the people that we're working with. But locally, I just want to speak to, I was hoping that Maggie Cahill could come up and speak very briefly about, she's a clinic director of Hobbit Opco in Brockton, Quincy, and also works closely in Wareham. We also have Shannon DeMille, who is the center manager for Clean Slate here in Plymouth, as well as Anne-Marie Kennedy, who's the program director for the ARCH program, but I've asked her to speak briefly about the services that High Point provides, so that when you're out there, you know who to link to immediately. Also, as part of the training materials that we're going to send out after, there's a 7-page document about medicated assisted treatment programs in all of Massachusetts that helps provide information about location, hours of operation, and contact information.
Hi, everyone. This has been really great. Thank you for the efforts behind putting this together. I'm just going to speak real quickly to direct admits to a methadone clinic. That's one thing that I've been putting a lot of energy into, to try to develop the relationships, which Dr. Wally said. But more importantly, if you have a client, a patient, an individual that has overdosed, and especially a repeated person that you've had to Narcan prior, a direct admit is the way that we could bring a person on if methadone is determined the medicated assisted treatment the person wants. That's the key. So, you know, all I need is evidence that they've been Narcaned or urine analysis from an ER in order to bring them right on. And then I have, I can induce them and initiate immediately with that. And then the other thing, if you have people that are on methadone, that's a direct admit, hands down. They come on, they dose immediately. And I have 10 days to get them under a prescription of methadone. But there's so much that was said today that I could speak to as far as what we do at the clinic. I think one of the most important things that you need to know with methadone treatment is not only medical, when they come and take their medicine every single day, but we have a very strong clinical part of the program where we're required to set eyes on a patient clinically, weekly. I have 750 patients, and we do that through a group method, usually CBT or recovery, relapse prevention. Those are the two focuses in the group model. So Thanks.
Hello, everyone. My name is Shannon DeMille. I'm the center manager at Clean Slate in Plymouth. I just wanted to let you guys know a little bit about our program. So at Clean Slate, we provide Suboxone and Vivitrol. We do see most of our patients weekly. We also provide care coordination. I have a care coordinator on staff that will help that patient with anything else that they need, whether it's primary care, counseling, psychiatry, anything else, a transportation voucher, anything that patient may need. We're going to have them sit with our care coordinator and help them put all those pieces of the puzzle back together and help them on the road to recovery. We also have a licensed alcohol drug counselor on staff too that also provides one-on-one coverage, as well as he can refer out immediate assistance if for some reason my provider just feels that they need to speak to somebody a little bit more in depth. They can sit with our LADAC as well. I can get patients in within about 24 to 48 hours. They do not need to go through detox first. They can come directly to us. Sarah has all my information and it can be sent out to everyone. You guys can always reach out to me, give me a call. If I can't help, I'm sure I can get somebody who can. Thank you.
I'll be brief. Again, Anne Marie Kennedy, Program Director for the ARCH program. We actually already go into Brockton Hospital as well as Good Samaritan, but we provide an array of services that obviously include the medical assistant treatment program, anywhere from 7 to 10 days. We immediately try to get the overdose patients into treatment. We partnership is big for us. We work with many other facilities if we happen to be full for placement for the individual. If we're not able to get them inpatient, we have our recovery coaches, we have community support persons, which is known as CSP, and we also have outpatient in Brockton, that's 20 Meadowbrooks, 30 Meadowbrooks. We also have Plymouth, we have ATS, we have clinicians licensed, so we try to do array. We go across the board so that we can help that individual to turn their life around and get acclimated back into society. So again, High Point, we're there. We're always open for networking and partnership. Thank you.
Thank you for your time today. I know you're very busy, and for bringing hope and information out into the community.
Happy holidays. Thank you. Great job.